2 down and 3 to go. We're going to be looking at the anatomy of the pleura as well as how to diagnose pleural effusions. And we're going to look at some of those procedures that help us to actually gain fluid from the pleural space to diagnose. Insertion of chest tubes, for example, as well as thoracentesis. We'll look at CAT scans and chest x-rays and how pleural effusions look and act. As a healthcare professional, whether you're a physician assistant, a physician, a surgeon, or a dentist, you're going to come across patients who have diseases of the pleural cavity. Even if they present to you with a simple complaint of a chronic cough or hoarseness, this understanding of the anatomy of the thorax and the pleural space, as well as a basic understanding of pleural effusions and whether they're benign or malignant, will help you diagnose, treat, or refer your patient to the appropriate specialist. Continuing with part 3 of clinical anatomy of the thorax, we'll look at diseases of the pleura after we first explored the anatomy of the pleura. What is the pleura? The pleura is the lining of the chest cavity. That's called the parietal pleura. And then there's the lining on the lungs itself. That's called the visceral pleura. We'll look at both, including fluid accumulation within the thoracic cavity. That's called a pleural effusion. How to treat it, how to remove it, how to diagnose it, and what all of this means. We only have 2 more presentations to go, so hang with me. There's a lot of information here. What is the pleura? It's a mesothelial layer which covers the parietal and visceral surfaces of the thorax. It covers the interior innermost aspect of the thoracic cavity, and the visceral surface covers the lung. It's about 2,000 square centimeters in size, which is, quite frankly, a lot. It has 5 layers: a mesothelial layer, a connective tissue layer, an elastic layer, and then there's a loose connective tissue layer, and then, of course, a deep fibroelastic layer. Truthfully, from the operating surgeon's point of view, it peels off much like saran wrap. We'll see videos of a pleural biopsy later, so I won't ask you to memorize the fact that it has all 5 of these layers. Just know that there are 5 histological and microscopic layers, and that it covers a really big surface area. The pleura is also covered with a lubricating fluid, which is made up of glycoproteins and hyaluronic acid. Here's what I do want you to remember. In the adult, there's only 1 to 10 cc's of this fluid. That's not much, and it spreads out between the parietal and visceral pleural surfaces 10 micrometers thick. In any given day, the lymphatic clearance from this wide range of tissue is about 700 cc's a day of lymphatic clearance. Lymph is usually pumped through this system by the respiratory mechanism. 20 to 160 cc's of physiologic fluid a day crosses the pleura. 700 cc's a day of lymphatic clearance. Take-home message from this slide: 1 to 10 cc's is normal. Commit that number to memory. It's not a lot of fluid. There are usually 3 mechanisms that cause a pleural effusion, and that is excess fluid in the pleural space. Abnormalities in Starling's equilibrium, that's one mechanism that can cause pleural effusion. Increased capillary and mesothelial permeability, that's another, and interference with lymphatic drainage, such as when cancer plugs up the lymphatics, such as lymphoma, or perhaps even an inflammatory process like pancreatitis or pleuritis. Usually it's 3 of these all acting together which cause pleural effusions. So before we can talk about pleural effusions, let me show you a normal chest x-ray. Here you can see the lungs and the heart, and the red arrows show the costodiaphragmatic recesses. Nice, sharp, triangular points. There's no fluid here. Remember this. This is a normal chest x-ray, and when you look at the costodiaphragmatic recesses, it should appear as nice, triangular, sharp points. Anything less, and it's going to be suspicious for excess fluid in the pleural space, known as a pleural effusion. Here's a large left-sided pleural effusion. Notice that the blue arrow is showing a meniscus where, just like when you look at a thermometer and you get a small curved meniscus, The same thing is happening here in the left thoracic cavity. We don't know what the cause of this left pleural effusion is, but it can have a unilateral appearance. This can be a result of congestive heart failure, malignancy, or even pancreatitis. Perhaps even trauma can do this. In that case, we would expect it to be a hemothorax or contain blood. Because we don't know what the cause of the fluid is, we can sample it and find out whether the cause is from pleuritis, pneumonia, cancer, congestive heart failure, all by chemical composition of the fluid. Therefore, we sample it through a process called a thoracentesis. Then we send it for a protein count. Protein count is the most important determinant of whether it's a transudative or an exudative pleural effusion. A transudate is basically an ultrafiltrate of serum. It has a low protein content, less than 3 grams per deciliter. Got to memorize this number, 3 grams per deciliter. If it's an exudative effusion, such as from inflammation or pus, the protein content will be higher. It's a result of increased permeability, and it has a high total protein content. It's a result of inflammation. You don't need to memorize this list, but it gives you an idea of those sources which can cause pus in the pleural space and inflammation causing an exudative effusion, such as a bacterial pneumonia or even cancer, which can plug out the lymphatics, perforate the esophagus and spill a couple of tacos into the mediastinum, blood, connective tissue diseases such as systemic lupus, pleuritis, even pancreatitis. But also look at the transudative causes: congestive heart failure, cirrhosis, nephrotic syndrome. You can even have pulmonary embolism, which causes this. But note that PE is in both columns. There are a couple of these which appear in both columns. I've highlighted and put in bold the most common ones which you'll see as a clinician: congestive heart failure, cirrhosis, nephrotic syndrome, atelectasis can all be causes of a transudative less than 3 grams per deciliter of a ultrafiltrate. An exudative or an inflammatory or infectious process such as pneumonia, cancer, or pancreatitis will lead to an exudative effusion. Also note that patients who have a heart attack get an exudative effusion. I would be suspicious that MI could also cause a transudative effusion. The most common way to diagnose a pleural effusion is going to be by a chest x-ray, but there are some physical exam findings which will tip you off to the cause of a patient's shortness of breath. If they have increased jugular venous distension and a fast heart rate, this can be strongly consistent with congestive heart failure. What if they have systemic lymphadenopathy? That might be a tip-off that they have lymphoma or cancer and might have a malignancy causing an exudative effusion. If they have finger clubbing or bone tenderness, that could suggest lung cancer, or abdominal ascites could suggest cirrhosis, or perhaps a malignancy such as ovarian cancer. Just the physical exam alone can give you a hint as to why the patient is short of breath. I doubt a physical exam alone will help you diagnose conclusively the cause of the pleural effusion. So I've already alluded to this, that physical exam is often not enough to detect a pleural effusion. Most of the time we need to do a chest x-ray, which will then lead us to a CAT scan, which is more sensitive. Ultrasound will also show us pleural effusion and is often quick and safe. Pleural biopsies and perhaps even sticking a camera into the chest called thoracoscopy, and perhaps sometimes we even need to tap this fluid via a thoracentesis. You'll see videos of all of this later to help reinforce not only the anatomy, but what pleural effusions are, how they're used to diagnose, and what we can do to treat them. Here's some more numbers to memorize. A chest x-ray can detect a pleural effusion if there's more than 150 cc's. If the costodiaphragmatic recess is blunted and is filled up with fluid, then we're suspicious that there's between 150 and 500 cc's of fluid. If you have more than 500 cc's, you'll get a meniscus, and many times you'll see opacification of the entire thorax. Opacification meaning you can't see through it on chest x-ray. So we know from the previous slide that in order to see blunting of the costodiaphragmatic recess, that we need to see between 150 and 500 cc's of fluid. Here, the yellow arrow is showing us a blunted costodiaphragmatic recess. On the left, it's normal. The right, however, is blunted. Therefore, this patient has a unilateral pleural effusion, at least based on chest x-ray. A CAT scan might show us, however, that the patient has bilateral pleural effusions and we just can't pick it up on a chest x-ray. But for now, we're suspicious unilateral pleural effusion, blunting of the right costodiaphragmatic recess. Here's a lateral view. Note how the red arrow is showing blunting of that triangle. Therefore, we know that there's between 150 and 500 cc's of fluid extra in this chest. And also, the blue arrow is showing us the blunting anteriorly. So there's definitely fluid layering out here. If you look closely, between the red and blue arrows, you can see the line indicating the hemidiaphragm. What's most important here is not how much fluid. What is important is that there is excess fluid. So I've just told you that in order for a chest x-ray to show a pleural effusion, that we need greater than 150 cc's of fluid. And we just looked at a lateral chest x-ray, which is strongly suspicious that there's more than 150 cc's of fluid. But in reality, that lateral chest x-ray is more sensitive than the anterior chest x-ray. A lateral decubitus chest x-ray, that is one where we actually lay you down on your side and take an x-ray, can detect a effusion as small as 5 cc's. In general, any layering effusion that shows us at least 1 centimeter of fluid on a decubitus chest x-ray, that is one where the patient is lying on their left or right side, is amenable to drainage. So again, the numbers that you need to remember at this point are 10 cc's of fluid is normal, more than 150 cc's can show us blunting of the costodiaphragmatic recesses on an anterior chest x-ray, a lateral chest x-ray can show us a little less, and a lateral decubitus chest x-ray can detect as much as 5 cc's of fluid. This patient is lying with their right side down. You can see from the letter A that there's a lot of fluid in the patient's right chest. B measures from the middle sternum to the lateral chest wall. A is the amount of fluid. I would estimate from looking at this film that there's at least 500 cc's of fluid in this patient's chest. But the purpose of this x-ray is to show you what a lateral decubitus chest x-ray is and how we take them. We can also see other signs on a chest x-ray that may suggest there's fluid there. Accentuation of the fissure. Sometimes on a chest x-ray, the fissure stands out and waves hello at you. Usually that happens because there's fluid in it. You can also see elevation of a hemidiaphragm or separation between the lung and the subdiaphragmatic gas, which would be seen between the lung and the stomach. Any of these can be suggestive that there's more fluid in the thoracic cavity. There are also many other signs that can give us a clue that the patient has a pleural effusion. We've already spoken about whether it's right-sided or left-sided. You can also look at the size of the heart. If it's a giant heart called cardiomegaly, we can be suspicious that the patient has a cardiomyopathy or congestive heart failure. That may give us a clue of why this patient would have a pleural effusion. What if the mediastinum looks really wide? What if there's cancer or a tumor in the posterior mediastinum? Or what if the lungs look funny? Is it possible the patient has asbestosis or mesothelioma? Exposure to asbestos can cause thickened pleural calcifications which show up on chest x-ray. And of course, mesothelioma, which is a cancer, can also show up as a thickened pleura. All of this can be seen on a chest x-ray. And of course, what if the bones are being eaten away, for example, prostate cancer? This may all give us signs that the patient has a pleural effusion and may lead us to the cause of that pleural effusion. Here's a patient with asbestos exposure. Note the red arrows which are pointing to the pleura. Here the pleura is about 1 centimeter thick. This patient may have a mesothelioma, which is a malignancy of the pleura. We know he has had exposure to asbestos, but whether it's generated into a malignancy isn't clear. He'd have to have a biopsy of the pleura done, but that's not the point. Here we're trying to show you, by looking at the red arrows, the thick 1 centimeter peel of pleura in this patient's left hemithorax. We know that if you take a patient and lie them flat and take a chest x-ray called a supine chest x-ray, that it is less sensitive than any other type of chest x-ray. We've already spoken about the anterior chest x-ray, or what's called the PA film, and the lateral film. Technically, a PA chest x-ray is where the patient's chest is right up against the x-ray plate. The beam then travels from posterior to anterior. The lateral film, of course, is taken with the patient with his arm up over his head, and the beam is shot laterally. But we can also put the patient in a decubitus position. What happens now if we put the patient flat on a table and take a chest x-ray that way? This supine chest x-ray is like taking a glass full of water and throwing it on the ground. It's flat, it spreads out, and it doesn't show up very well on chest x-ray. But there's a couple of things that can lead us to conclude the patient may indeed have a pleural effusion on one of these supine chest x-rays. We can see apical capping. This means that there looks like little caps over the apexes of the lungs. There's also blunting of the lateral costophrenic angles. You can lose the image of the diaphragm. And of course, when you look at the hemithorax, it looks like it's cloudy, or you're looking through a piece of ground glass or bathroom glass where you can't see through it and it's really hazy. All of these can be signs that there's a pleural effusion. Here's an example of a supine chest x-ray, and the red arrow is showing an opacified left hemithorax. It's cloudy because the fluid has layered out, just like if you've taken that glass of fluid and thrown it on a plate or thrown it on the ground. The haziness of this left hemithorax is highly suggestive of a left pleural effusion. There are other ways that we can diagnose and even tap a pleural effusion. Ultrasound is safe and helpful. It's very helpful for locating a loculated pleural effusion. This is an effusion which is like multiple small balloons in the chest. Each of these little balloons is separated by septa and perhaps contains pus or infected fluid or tumor cells. Ultrasound can detect a fluid collection of about 5 cc's or greater. It's pretty sensitive. Here's an ultrasound showing us pleural fluid. On the left, we see a fissure, which is full of fluid. On the right, the lung is collapsed because there's so much fluid in the hemithorax that it's compressing the lung. Here's examples of loculated pleural effusions, like multiple small balloons thrown in lying next to one another. These are hard to drain because you have to drain each one of them separately. The right also shows us the same, multiple septa, multiple fluid collections. CT scanning, however, is the most sensitive way to assess a pleural effusion, or pneumonia, or atelectasis. Atelectasis means the lung is partially collapsed. That's like when you just start to get sick and the physician puts his stethoscope on your back and he can hear all of these noises rumbling around. That's a sign that the alveoli may be collapsing under infection. That's called atelectasis. CT scan is very sensitive for picking up pleural fluid and shows up as a sickle-shaped opacity in the most dependent portion of the thorax. It can be highly suggestive of the cause of this fluid collecting. In a trauma patient, it could be bleeding. If the pleura is thick, like that CAT scan we saw earlier, it can show infection or asbestosis or even mesothelioma or cancer or fractured ribs. CAT scan is the most sensitive. Here, let's look at some transverse sections on CAT scan. In image labeled A, the red arrow is showing us a large pleural effusion in the right posterior hemithorax. In B, we can see from the blue arrow all of the fluid which is in the dependent position in the hemithorax. The green arrow in image B is showing us atelectasis. Those are called air bronchograms. where air has collected into the small segments of the bronchus, and it is separated by a layer of atelectasis and infection around it. So the blue arrow is fluid, the green arrow is an air bronchogram, and the dependent portion below that green arrow shows us collapsed lung. Then in image C, the yellow arrow is showing us the same thing, an area of pneumonia, and the dark blue arrow is showing us the fluid which is labeled out. B and C are showing similar pathology. Having now spoken about chest x-ray, ultrasound, and CT scan, what about MR scanning? MR scanning gives us no useful information over and above what a CAT scan does. It's too expensive, it's not efficient, it's too time consuming, and it takes too long and can be dangerous. Now we need to find out what is this fluid and what's causing it. We need to tap some of this fluid. This is where your anatomy comes into play. We're going to stick a needle into the thoracic cavity. We want to avoid the vein, the artery, and the nerve bundle which lies on the inferior most aspect of the rib. And we're going to send some of this fluid out for cultures, protein, LDH, etc. And at the same time, we're going to pull this fluid out of the patient's chest so they can breathe easier.
Thoracentesis is performed to assist in the diagnosis and therapeutic management of patients with pleural effusions. After anesthetizing the skin in the typical wheel fashion, anesthetize the deep tissue. Insert the needle above the rib to minimize manipulation or laceration of the vascular bundle located beneath the rib. As the needle advances, identify the pleural space by the presence of pleural fluid aspirate in the syringe. Placing a sterile gloved finger on the needle at the point where it exits the skin approximates the length of the insertion for the thoracentesis needle or catheter. During needle insertion, the open stopcock valve allows aspiration of pleural fluid while minimizing the introduction of atmospheric air. The pleural fluid is used for laboratory testing to help delineate a differential diagnosis.
This is a video in clinical medicine from the New England Journal of Medicine.
Thoracentesis is used diagnostically to establish the cause of a pleural effusion. It can also be performed to drain large effusions that lead to respiratory compromise. Limited data exist regarding the safety of thoracentesis in patients with coagulation abnormalities. The procedure is probably safe in patients with mild or moderate elevations of the prothrombin time or partial thromboplastin time. The decision to use fresh frozen plasma or platelet concentrates in patients with clinically significant coagulopathy or thrombocytopenia must be made on an individual basis. The procedure should be used with care in patients who are receiving mechanical ventilation, since positive pressure ventilation may bring the lung close to the thoracentesis needle and increase the risk of pneumothorax. Thoracentesis should be deferred in patients with severe hemodynamic or respiratory compromise until the underlying condition can be stabilized. In patients who have small or loculated effusions, the procedure should be performed by experienced operators, ideally with real-time imaging guidance. The thoracentesis needle should not pass through sites of cutaneous infection such as cellulitis or herpes zoster. Numerous devices, which are frequently available in prepackaged kits, can be used to perform thoracentesis. You should become familiar with the specific devices available at your institution. In this video, we will use a standard intravenous over-the-needle catheter assembly to demonstrate the procedure. For sterile preparation of the site and administration of anesthesia, you will need a skin cleansing agent, sterile gauze, sterile gloves, a sterile drape, a hemostat, which is optional, 1 or 2% lidocaine, and a 10 milliliter syringe with a 22 to 25 gauge needle. For the collection of pleural fluid, you will need an 18 to 20 gauge over-the-needle catheter, a 60 milliliter syringe, and a 3-way stopcock. You will also need sterile drainage tubing, specimen tubes and a large evacuated container, and a sterile occlusive dressing. Explain the procedure to the patient and obtain written informed consent. You should also verify the patient's identity, mark the correct site, and conduct a pre-procedural timeout. The timeout, which takes place immediately before the procedure is started, consists of confirmation by all members of the care team that the patient's identity, the procedure he or she is to undergo, and the site of the procedure are all correct. You will need an assistant to help position and monitor the patient and assist with the collection of pleural fluid. Place the patient in a sitting position on the edge of the bed with his or her arms resting on a table. The height of the effusion is determined by auscultation and percussion of the posterior chest wall. With a skin marking pen, mark the needle insertion site. The site should be 5 to 10 centimeters lateral to the spine and at least 1 or 2 intercostal spaces below the top of the effusion. The needle should not be inserted below the 9th rib. If available, bedside ultrasonography can be used to help visualize the effusion. In the patient in this video, the pleural effusion is easily visualized, as are the ipsilateral lung and the liver. Prepare the area with antiseptic solution and apply a sterile drape. Using a 25 gauge needle, place a wheel of local anesthetic such as lidocaine along the superior edge of the rib that lies below the selected intercostal space. Switch to a 22 gauge needle and begin to anesthetize the deeper tissues. The inferior surface of the rib must be avoided, since the intercostal vessels and nerve are located in this region. At this point, walk the needle over the superior aspect of the rib, alternately injecting anesthetic and pulling back on the plunger as you advance. Once the needle enters the pleural space, pleural fluid will begin to fill the syringe. Inject more anesthetic at this point to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle. If available, a hemostat may be attached to the exposed portion of the needle to mark the depth of the pleural space. Attach an 18 gauge over-the-needle catheter to a syringe and advance it along the superior surface of the rib. Keep pulling back on the plunger as you proceed to the predetermined depth of the pleural space. Once fluid is aspirated, immediately stop advancing the needle and guide the plastic catheter over the needle. When the catheter is fully inserted, remove the needle as the patient exhales or hums. The exposed hub of the catheter should be covered immediately with your finger to prevent the entry of air into the pleural space. Next, attach the 3-way stopcock and large syringe to the catheter and continue to aspirate fluid. When this syringe is full, adjust the stopcock so that it is closed to the patient. The stopcock should be open to the patient only when fluid is being actively drained. If additional fluid needs to be drained for therapeutic purposes, attach the collection tubing to the stopcock and to the evacuated container. Open the stopcock to the patient and to the tubing and allow the evacuated container to fill. Generally, you should remove no more than 1,500 milliliters of pleural fluid. The removal of larger volumes may result in post-expansion pulmonary edema. On completion of fluid collection, you should rapidly remove the catheter as the patient holds his or her breath at end expiration. Cover the needle insertion site with an occlusive dressing and clean the surrounding skin. At the end of the procedure, make sure that all needles are placed into appropriate safety devices. Aspirated fluid should be placed in specimen tubes before the large evacuated container is filled or while it is filling. A tube without additives should be used for chemical analyses such as the measurement of lactic dehydrogenase, protein, and glucose levels. An EDTA-treated tube should be used for the cell count and differential count. Specimens for cytologic and microbiologic analyses and for other tests may be required depending on the clinical circumstances. These are discussed in further detail in the accompanying written supplement. Analysis of the pleural fluid will help differentiate a transudate, which is commonly caused by congestive heart failure or cirrhosis, from an exudate, which may be caused by processes such as bacterial pneumonia, cancer, or trauma. Pneumothorax is uncommon after thoracentesis, and when present, it rarely requires the placement of a chest tube. Chest radiographs are not required after simple, uncomplicated procedures. Radiography of the chest should be performed if air was aspirated during the procedure, if chest pain, dyspnea, or hypoxemia develops, or if the patient is critically ill or undergoing mechanical ventilation. Other complications of thoracentesis include pain, coughing, and localized infection. More serious complications include hemothorax, intra-abdominal organ injury, air embolism, and post-expansion pulmonary edema.
Now that you've watched the video on thoracentesis, you know what we're talking about and why the anatomy is clinically relevant. There are some times, however, where we absolutely cannot do a thoracentesis. If the patient has dementia, or they just won't consent, or they won't cooperate, perhaps they're on medication or drugs, or they're combative from a trauma, or their blood pressure's in the toilet, they're hemodynamically unstable, or they have airway compromise, such as after a car wreck, or their blood is thin from the use of Coumadin or warfarin, or perhaps they have von Willebrand's disease, or their platelet count is too low and they could bleed from the procedure, or if they're on high pressure ventilation and respiratory distress. I will tell you that the last one, high pressure ventilation, is not really so much of an absolute contraindication as it is sort of a relative contraindication. Sometimes you need to do a thoracentesis on a patient who is on a ventilator so the ventilator can be more efficient. We'll talk about this more in just a second. Then there are some times where we would like to do a thoracentesis and we can't really do it safely. Loculations, for example, are really hard to tap. You'd have to tap all of the small little bubbles from a loculated pleural effusion, and that's just not possible. Or if you're planning on putting in a chest tube, or if they already have a chest tube that just might need repositioned to drain the fluid. Of course, trying to drain a fusion that will simply not layer out. If you can't get a good level, it's difficult to put a needle in it to try to drain the fluid. If there's been prior chest trauma, for example, multiple broken ribs, or the possibility that the patients had prior or even recent thoracic surgery that may have caused adhesions of the visceral pleura of the lung to stick to the parietal pleura. Any of the above are relative contraindications. Well, after watching that video of a thoracentesis from the New England Journal of Medicine, you know right away that one of the possibilities is you can cause a pneumothorax. Of the patients that get a pneumothorax from thoracentesis, 1 in 5 might require a chest tube or a Heimlich valve to re-expand the lung. Other complications of thoracentesis include putting the needle in and getting a dry tap. You don't get anything out. You can also make the patient vomit or get lightheaded or dizzy, called a vasovagal reaction. Or you can have hypovolemia and or bleeding, also infection. One rare complication of a thoracentesis is called re-expansion pulmonary edema. You put the catheter in the hemithorax, you hook it up to a suction bottle, and it sucks on the lung parenchyma so much that the patient goes into a congestive heart failure. Don't drain more than about 1,500 cc's on an attempt, and drain no more than 200 cc's every 2 hours after you've removed that initial 1,500 cc's. I've had this happen to me. It's very rare, but it does occur. The patient will have immediate shortness of breath after the re-expansion pulmonary edema, and it would be treated with diuretics and supplemental oxygen. Well, that's it for part 3. Let's go on to part 4 after you take a small break. And remember, the information contained herein is provided to you as a student under general copyright laws. That law is listed here. Remember, 1 copy per student of this presentation is permitted for educational purposes, and redistribution of copyrighted materials is not permitted by law. Thanks for listening.